Good evening all. This is a 10-year-old boy diagnosed to have congenital heart disease soon after birth, and he was having no cardiac symptoms. Now, he's on examination, he's weighing around 32 kilogram, pulse rate of 75 per minute, BP 110 by 68 millimeter of mercury, saturation 99%. CVS examination S1, S2 is normal. He's having a systolic threaded lower left sternal border, a pansystolic murmur of grade 4 by 6 over the left sternal border. Chest X-ray, cytosoltus, levocardia, CTR of 55%, MPA is dilated, mildly prominent hilar pulmonary vascular markings. ECG showing sinus rhythm with a ventricular rate of 75 per minute, QRS axis is 60 degree, LV dominant. This is the echo. First picture is of a 4-chamber view showing dilated LA-LV. Second picture, you can see the perimembranous VSD shunting left to right. This is a parasternal short axis view where at 9 o'clock to 10 o'clock position you can see the perimembranous VSD with RCC prolapse. On measuring, it is around a 5 millimeter perimembranous VSD restricted by RCC prolapse with an IV gradient of 110 millimeter of mercury with a dilated LA-LV and good biventricular systolic function. Plan is VSD device closure.
So can we see the cath lab? We cannot hear, we cannot see. All we can see is these slides. Yeah, we can see you, Dr. Worakan.
Hello?
So what's the plan,
Yeah,
Dr. Worakan?
we can see you now, Dr.
Okay,
Worakan.
hi. So can you hear me now?
Yeah, Doctor,
Yes,
we can
yes.
hear you.
Can you hear me now?
Yes.
Okay,
Yeah.
so if you can hear me, that's a bit delay, probably about 2 seconds. So, so this is a case, you saw that at 10 years old. So as a routine, we're going to check it for the transthoracic echo, and it looks very nice to me to close with the device. And for educational purpose, so this patient, we also do the transesophageal echo for you. So Anil, if you can show the transesophageal echo a bit of what do we have here?
Hello.
Yes, we can hear you, Anil.
Hello. Yes. Yeah. Now I have recorded some transesophageal, which we can see is a perimembranous VHD measuring around 4.5 in various views with a gradient of 100 and there is small aneurysm formation and there is a gap between the VHD and the aortic valve. There is no AR. So maximum I found around 4.5. So then I think Dr. Worakan has done that.
Yes, thanks, Anil.
angiogram, so he
So
can talk.
once again, I think it's kind of practice around the world, which is different in terms of the assessment of the VSD. So in some center, they will do just transthoracic. In some center, they may also use transesophageal to guide the procedure. But for here, I think for the educational purpose, as I said, so we will do all of them, right? So now you can see the angio, right?
Yeah, we can see the angio, but after echocardiography, what is your thought process? What is your choice of device you are thinking? Because aortic, there is an aneurysm. Are you going to seat distal to the aortic valve? I mean, what is your thought process after the echocardiography?
Yeah. So maybe ask the audience first, huh? Or the panelists, if they can suggest me, what should I do?
So really, what are the options, as Dr. Worakan is saying, do we go for, the size is coming out to 4 millimeters, right? Subrata?
4.5.
4.5
Yeah, something
millimeters.
about 4 to 5 millimeter.
4 to 5. Yes.
I think it's about
So what is,
4.5 to 5
what is the
millimeter.
choice you are
So
giving to
that's
the audience?
roughly.
What is the choice of device you are giving to the audience?
Oh, okay. So the choice definitely because here we can have the ADO 1, we can have the double disc device like a LaPu VSD device, or we can have something like ADO 2 or the MFO.
So you are thinking of a double disc device. So audience, we are basically thinking of a double disc device. The choice is between double disc device, the three mentioned, or a PDA device, a regular PDA device. So,
Yeah.
So how many, maybe with the raise of hands, how many for a double disc device?
Yeah, please.
So we have quite a number for the double disc device, and how many for the regular PDA device? So I would say it's more for a double disc device, but the difference is not much. What about the size? What is the size you're looking at? Maybe for if you have to use a double disc device, what size, and maybe a PDA, what size?
May I give you a choice then? Because it's about 4.5 with angio also looks pretty much the same. And so maybe 6, 8, or even bigger than that. So maybe if you can show of hands, if anybody prefers 6.
6, 8.
I can't see, but please let me know.
Okay.
6, 8.
6,
6
8.
or 8 or 10.
6, 8 or 10 of a...
6, 8 or 8, 10.
So we have a choice of 6, 8 and 10. A double disc device, you mean to say?
Yeah.
So you're sure you're not going for a PDA device?
So, but double... Yeah, you are not doing PDA device anyway.
I don't.
No, PDA.
I think this particular case, I prefer to use double disc device.
So since it is a choice of a double disc device, how many for 6, how many for 8, how many for 10? So 6.
It will be too much.
Yeah, I think so. It's too much.
So we have Dr. Dalvi for the comments.
Worakan, I wanted to make 2 comments on this angiogram.
Yes,
You
please.
know, I'm really concerned about the proximity of the aortic valve to the jet of the VSD, at least in some plane. And my second comment was that I'm not impressed by the type of aneurysm that is formed. Although echocardiographically seems to be impressive, angiographically it doesn't look like any kind of aneurysmal tissue. And if you look at the base of the interventricular septum, it is quite thick. So many times ADO1, if you put in this cases like this where aneurysm is not well formed, the disc tends to sit on the LV side and the stump of the ADO sits on the top of the crest, and it can then tumble into the left ventricle and go into the aorta. So if at all I have to use a device, I would be happy using a double disc device in a case like this where aneurysm formation is not that good and where I'm concerned about the stability of ADO1. And I would use a 6 millimeter muscular VSD.
But you have a concern about the proximity?
Yeah, I have a concern about the proximity of the aortic valve. So any stiff device there, it really concerns me, but my experience is very limited. And you guys have much more experience than me.
Would we err towards a softer device like a ADO2?
ADO2 is not a bad option if at all I have to use, because I feel that I might entrap one of the leaflets of the aortic valve.
What about an MFO?
Would MFO be ideal for this, sir? Multifunction.
So thanks for sharing, Bharat and all the audience.
So
I think what Bharat mentioned is very, very important, because in this particular case, as a new showing by the echo, that looks as if there's some aneurysm, but not very clear. And then also this patient got limited rims on the aorta because it's very close to the aortic valve. So as I said, I prefer to use the double disc device, which is soft. In order to avoid, the migration of the valve of the device, and also the not too much or too tense touching the aortic valve. So that's why in my feeling, I would go for double disc device. So for double disc device, we can use either MFO, ADO2, or what we have here now is a membranous device from the Lepool company. If you can show. This one.
Please zoom on that.
Why not a
so here's the
zoom on the device. Srinivas wants to raise a point.
Why not an asymmetric device in this patient, where you can actually stay away from the aortic valve? If you are committed to doing a device in this patient, asymmetric device.
Well, Lepool actually produced a variety of the VSD device, and this is one of them. This is a metric device. This is actually 6 millimeter. It's +4 on this side and +4 on the other side. So this is a metric device. They also produce a symmetric device, which is this on the left side is a bit larger, than the right ventricular side. And also they have the eccentric device. So in my experience, I never use eccentric device, so that's why this is not my option. And second device for the asymmetric device, which is bigger on the left side, I think this is also not an option for this particular case. So this is what I think that we're going to use today for this patient. But before we proceed, I think I want to show you also the next thing that we want to let you know. Can you move to the fluoroscopy? Okay, so in terms of crossing, so we can show you that at least two techniques that we can use to cross. So this one, actually, we just use the pigtail catheter together with the terminal Y, and then you can see it's nicely jumped into the defect, without any traumatized to the, the septum or whatever area. So that's also one of the possibility. And second one, can you? And this is what Sourabhi did actually. She put the JR catheter onto the primary artery, and then just using the terumo Y, just slowly coming down. And so some doctors, they may use the pressure tracing to just checking whether they are into the left ventricle or not. But on her experience, she just used the catheter together with the Y, and then just trying to checking. Just wait for a sec, and it will come.
So with this particular setting of a concern being aorta, would you like to have a retrograde approach or an antegrade approach with your LEPO device?
So this is a thing I would like to ask the audience and all the panelists. So whether should I go from the retrogradely approach or antegradely approach, or any suggestion for that?
Maybe with the raise of hand, how many for the antegrade approach?
Advantage of deploying it
so now you see that it crossed already.
And how many for the retrograde approach? So there are more people for the antegrade approach, and most of them are not certain. But yes, we have a very heavy hand, even Dr. Dalvi's hand for the
antegrade advantage would be that you can assess the aortic valve before you release. So if you go retrograde, you will not be able to assess the aortic valve, whether there is, till we release. Once you release, and it's all done.
What is the profile of the device, this LEPO device? What is the sheath it has to go through? I mean, when we have to go for antegrade, suppose, what is the sheath size you are looking for using this device?
Well, for the 6mm LEPO membranous symmetric VSD device, actually it takes 7 French sheath. But here we have 8 French. That was the smallest sheath that we have. So that's why we used 8 French. So in terms of the approach, because we discussed that already, I think we can do any kind which we feel comfortable with. And for this situation, Sourabhi would like to do it, in antegrade fashion to the left ventricle. So that's why. Next, please. So that's why after that, next, please, we just push the Y onto the aorta. Next, please. Okay. And then next, please. Okay, now we didn't form complete AV loop. Next, please. Patient is waking up, please, if you can sedate the patient a bit more. Right, and now we just use the exchange Y, not the slip one, but the regular one, and then just slightly, advancing the delivery system onto the left ventricular apex. Next, please. And then after that, as you may notice from the echo, that there's a little bit prolapsing of the aortic valve. So that's why we really need to confirm whether or not we should oversizing more than what we planned. So we routinely do angio. And as you can see here, it's almost completely blocked the flow by the 8 French catheter and sheath. So it means that for some reason, this hole is smaller than 3mm. So that's why I think we are quite, sure that even 8mm will be bigger than for this patient. So that's why we prefer 6mm. So that's what we have so far. And if you allow me to proceed the procedure, okay? So while I'm loading the device, maybe you can ask or discuss if any question you may have.
Everybody is spellbound. Because LEPU device is something which is actually maybe very new to many of the audience, many of us.
Okay. Right.
But
So you're gonna release.
being
Are
an
you gonna
8
deploy,
French
okay?
sheath, a retrograde approach would also, I mean,
Really?
agree the
That's great. Wait.
so with the 3 mm size, as with the risk of impingement on the aortic
let's
disc, we all agree that AODO2 device would be a nicer device, but probably LEPU device.
Well, in terms of the disc diameter, if we use ADO2, I probably will use 6x4. It means that the disc is, if I remember correctly, it's about 12 millimeter disc.
12, absolutely.
So it's even larger than this one. So I think the LEPU is more comfortable with this situation, in my opinion.
So LEPU
Okay, you go
LV
for
disc
that.
would be,
Okay,
say,
just
a
wait for a while.
for a 6 mm
Eco can be
waist
shown
size, what
small.
will be the LV disc of a
So
LEPU
what
device?
we have now, we want echo in small picture, okay, and the floor in a big picture, and hands in small one. Okay, right. So Anil, if you can go for
we can see the whole of the sheet running
Okay,
through
now
RA, RV and LV.
Go for
So
that.
we can see the whole of the device getting deployed
please,
as it is
throw.
coming. So you can carry on.
Yeah. Okay, slowly unsheath. Make it fully expand. Okay, very nice. Fully, right? Now you see by the echo, it's fully expand. Now just come back together, the whole set. You can do.
So we can see the device, one disc getting deployed. It is more close to the, yes, it is slowly coming towards
Wait,
the
wait, until
VHD.
you see it. Okay, it's touching, right?
We can't
So
see
I'll
the
now
fluoro. The
change the
fluoro,
view.
Okay, can you?
we
can you
can't see the
fluoro a bit?
fluoro. If
Can you
fluoro can go
Fluoro
like
should be
together?
live.
Okay.
Yeah.
Now
yeah.
you just push the
So
cable.
I'm just showing in
Push.
other
Yeah,
views.
whatever you do. Yeah. Okay, now push the cable, please. Good.
Yes,
Very nice.
she's
Okay.
deploying.
Stop. Yeah, I do. Don't worry. Okay, Anil.
Yes, there is.
What do you see?
Yeah, we can
So
see the device. There is.
we're able to see the, we can't see the fluoro.
There is
We
minimal
can only
cathode.
see the echo live.
Yeah.
Echo and the cath lab live.
Oh, really?
Yeah, now we can see it.
Fluoro is not live, actually. Okay.
Yes, so we can see the disc is on the both side, and there is little catheter induced air possibly.
Can you make the echo big? Anil, our concern was the aortic valve. Yeah.
Yes. Yes. I am showing the aortic valve. There is mild air, and there is an catheter across now. So
Can you see, tell us, show us the relation between the aortic valve and the disc? Yeah.
yes, I am showing the disc and aortic valve both. It is not impinging, it is just below. So how much it is influencing, the air is very minimal though. And with the pigtail is also across, sir, now.
We can easily do a LV
take
angiogram
out the
and take out the
Yeah,
pigtail.
take out the pigtail. Na?
Yeah, we can
That
take out
will
the pigtail. Do a LV angiogram and take out the pigtail.
Yes.
Well, let me do angio first, and
one
then I pull it
injection
back.
and then
Okay.
you take out.
I'm not worried on the AR. I think it's because of the catheter, but just to show you after this. So zoom it, please, because we can't see the device clearly. Zoom it, please. Stop for a while.
No, I'm not doing fluorescence.
Okay. Zoom, and then we do one more cine. Can you check it, fluoro, please?
Yes.
Fluoroscopy.
Fluoro?
Yeah, just to check. Okay. Now move the table a bit, approximately. Okay.
Yeah, fluoro again.
All right. Okay. Now we do one more angio here. Sorry, wait for a while. Fluoro, get fluoro a bit. Fluoro.
Yeah. No, so
Okay. Now Sydney,
Sine?
please. Okay. So what do you think?
Looks very nice. You can take out the pigtail and reassess the AR.
I think so.
Pigtail.
Yeah.
Yes.
We can show you.
So we can just take out the pigtail.
No. Why, please? And one wide, please.
On
Follow,
echo,
please.
we were not able to demonstrate, but we did have a mild AR. But AR is very mild. Like.
Yes.
No, not completely, because we need it.
So now I think you have pulled out?
Yeah, I did.
Yes, yes, I
so
saw that.
What do you see, Anil?
So that the air has come down.
Sir, it's a
is
good
sweep of
idea to
air
take
now.
one aortic root injection because I think the disc is touching the aortic valve. It's tilted also, the upper margin.
So
Okay,
yeah, it's
can
always
you
a good
move
idea for
the
AR, but
picture
whenever
capture down?
echo is always a better
Furrow
modality
first, furrow
to
first.
assess the AR than a
No, but if you see
Yes,
the
and
disc
Wait. Thermal wide,
carefully, it's tilted.
please. DMAX.
It's touching.
Should I see?
Even if AR is not
Okay.
there, it may damage the aortic valve over a period of time.
Wait.
So Dr.
Come back,
Worakan,
come
the
back, come
concern
back.
raised is whether the
Come back.
LV disc is touching the aortic valve.
Now go for that.
Dr. Worakan, can you hear us?
Well, as we
Yeah.
discussed previously, that we cannot avoid touching the aortic valve. So that's why we need to use a soft device. And for me, the softest one device will be the ADO2. But in this particular setting, my opinion, I think the LaPoo device should be okay because it's not that stiff, but it's not as soft as the ADO2. Flash, please. But let's see.
So would you accept this AR?
There is mild air. There is mild
Wait for
air.
a sec. Okay,
There
one
have
more
been case
angio here.
reports that this kind of disc deployment has injured the aortic valve during follow-up.
Yeah, Mac, please.
Perforation.
Yes, this is this. Yes. Yeah,
So Dr. Worakan, with all your experience,
please?
what is your take on this AR and what
Sir,
is
just-
your thought?
Not acceptable.
Are you accepting it?
I'll discuss on that after angio, please. Yeah.
Sir, just one point. The AR which was previously was trivial or it was definitely a less. Everybody agrees with that. And yeah, and after device, the AR is
Okay.
definitely more compared to the previously. And we can see some edge of the device is impinging on the
You
sinus.
see the aortic root.
So this everything
valve
goes
is
This is more.
in favor that
indented by the leaflet.
over the period of time the
LV
device
margin.
So there is a concern, but
Yeah.
but we always anticipated this particular device is going to rub on the aortic valve. We had a discussion, the softest device available.
Well-
we thought the softest device is ADO2, and the next best option was a LEPU.
If you can have a look on the echo now, please.
Yes.
Anil, if you can show what do we have here.
So
I think AR severity is getting more.
So air is
eccentric.
more. Definitely what we
Right.
started, which is a whip of
Yeah.
air. Now it is more. Definitely, I also agree with that point.
And I think the answer is definitely we cannot accept
Softer device could have been better.
it. Yeah.
Yes, either we can go with the softer device or we should not devise this.
Well, I will try to use a softer device. This is what I'm thinking. But I think definitely we need to remove it now. So maybe if you go for the lecture and then we come back again after we have some progression. Is that okay?
yeah, this way.
Yes, thank you, Dr. Worakan.
Okay. All right. Thank you. Yeah. So just come back with you. Maybe Anil will show you what we had immediately after we remove the device.
Okay, this is the where we
Echo
left
big,
you.
please.
The last memo device, there was definitely concern for AR. So we removed the device, and after removal of the device, there was a small whip of air. The significant air component was not there. So Dr. Worakan then recrossed and snared. I
Yeah,
think you
so
can
thanks,
tell.
Anil. So that's the thing I think we need to show because immediate after we remove the
Showed.
device,
I have showed that.
is completely,
No, there was a
disappear.
whip of air.
Yeah, so it means that it's device related definitely. So that's why we decided to use a software device, and Anil agreed that we probably can use the ADO2, huh? And the size we select is actually 5 by 4. So we select 5 because the disc on the left ventricular side will be about 10 millimeter. So with that,
want to show the fluoro? No.
yeah. So with that, it's more comfortable. So then we, create the AV loop, and then next, please. And then we deploy. This time, I prefer. Well, my just personal preference. I prefer to deploy from the aorta, so that's why I use that. But one point I would like to make while using this ADO2 device, because if you open just one disc and you don't open the body, sometimes when we try to pull the thing back, it's completely, back more to the right ventricle. So with that, you may losing a chance to put the body into the interventricular septum. So I routinely open two discs, the LV disc together with the body, and then just slowly by checking by helping with a nail, and maybe you can use fluoroscopy as well. You can see that slowly the device will jump back into the left ventricle, and you don't worry about too much protruding into the right ventricle, because now the body is in between the septum already. So after that, just to check whether it's okay or not in terms of the position, and then you just, rather than pulling the sheath, just pushing the cable, just to sandwiching the interventricular septum, and as you can see here now by the fluoroscopy. So with
the
that,
air
yeah,
definitely is not significant, is a small minimal whip of air only.
So see the echo, right?
Yeah.
Okay, so by echo, it's a very minimal aortic regurgitation, and that's also proof that this, for some reason, it's device related. So with that, so we also check the angio, because by echo it looks as if there's a minimal, or not minimal, but some leaks. So with that, you can see there's it's not completely blocked the flow. There's a leak around the device. So my routine also, I will always keep listening to the murmur if not sure. So with that, the murmur is grading about grade 2. So again, just confirm, just remove the pigtail back, and then ask Anil to recheck it before we release the device, whether or not AI is progressing. And Anil just confirm that there's no progression to the AR. So that's the reason why we just release the device. Next, please. Yeah, so that's after, this is what we are about to release. This is nothing, okay.
I think
now just final check angio. The residual shunt is getting even less. And again, Anil confirmed that AR doesn't progress. So I think we are happy ending here. The murmur is less than grade 1. And I think that's all for us to you guys in the auditorium. So any questions, any comments, please?
Excellent result. I think the ADO2 being a soft device helped you there, and also because of its shape, the left ventricle side of disc was away from the aortic valve. Now, any particular reason you chose to deploy from the aorta and not from the LV like the earlier attempt you made?
Well, because this is my practice, using deployment from the aorta, this is my routine practice. So I'm quite comfortable with that kind of, approach. I'm not worried on, injury to the aorta, because I know exactly I won't pull. I just let it drop into the left ventricle.
Yes,
so
that dropping was visible in the echo. In the TE, I could demonstrate. That was, we usually don't do TE, but in today's case,
yeah, it was
I
visible.
could see
Absolutely.
the device slowly coming down.
Good.
Right. So with that, maybe if no questions, so thank you much indeed for all the panelists, the moderator, and people there, and also thank the team here.
All the opinions are so nice.
And I think this is a good educational case to show that how AI can be manipulated by whatever we do. So thank you very much.
Excellent academic case.
Thank you.
Thank you.
Thank you.